Hello and welcome to today's webinar hosted by Gnome. We have with us today Dr. Charles Root. Dr. Root is the CEO of CodeMap, a firm that offers a wide variety of products and advisory services to diagnostic manufacturers, laboratories, and healthcare providers. Dr. Root himself has been working in this space for over 20 years. He holds a PhD in physical chemistry and nuclear physics. And today he's going to speak to us about the new CPT codes for genomic sequencing procedures, current and future reimbursement. And as the next slide shows, if you have any questions during the webinar, please go ahead and type them into the GoToWebinar control box. You'll see that little question area you can expand. Type those in, and we'll see if we can get Dr. Root to answer as many of those as possible during the talk. Also, for your information, this webinar is being recorded, and we'll be happy to share this with people again afterwards. With that, take it away, Dr. Root.
Thank you, Ben. Well, today we're going to talk about some rather far-ranging topics here, all concerning and focused on essentially the genetic testing and genomic sequencing more specifically. As you probably all know, we have new genomic sequencing codes that just became effective January 1. And so we'll talk about those codes, how they're used, what they mean, and then also how Medicare intends to try to come up with payments for them. We'll also hit on MAAA codes or MAAS codes. This is the multi-analyte assays with algorithms, because they oftentimes, as you put together genetic tests, they end up into this category. Likewise, which tests may be bundled with other services so you don't get paid for them separately. And then we'll talk some about how the coverage policy is evolving and developing. And then we'll end it up with a summary of PAMA. That's the Protecting Access to Medicare law that was passed in February. Well, no, it was last fall, but which in a sense will dictate how the future possibly goes with reimbursement for these type of tests. So we'll start out with the new genomic sequencing codes. These are essentially codes that use DNA or RNA sequence methods to assay clinically relevant genes, and that's a key factor in how these codes are defined. They're defined by their clinical application more actually than their technology or how you perform the tests. These codes can be either performed on germline or neoplastic samples. They include exome and genome procedures. And these procedures include virtually everything you could do, to measure the entire exome or genome. And another important factor is that each of these codes, each of the values reported, the genes and so on, whether it's duplications or structural, however, are considered to offer independent, significant medical value. So, in other words, the results of a genomic sequencing code is a set of data that each item in that set can potentially be important to the treatment of the patient. It's not a single result. It's not a result that's been arrived at by calculation or combination of all of the individual results. The coding rules, these codes are independent of method and specimen type at this point, although a lot of people are trying to modify that as they go forward. There is opinions that there should be more detail, but for right now, it doesn't matter whether you use cell-free DNA in the blood or if you're using tissue, etc. It's independent of specimen, and unless it's specifically noted, in the description of the code. And also, analysis does not have to be performed by next generation sequencing methods. You can use PCR, microarrays. You can use any method you want. The codes are, as they say, agnostic to that aspect. You're going to end up with, as you'll see, very broad codes that eventually will have a single payment, and you can do extensive analysis or less extensive. Everybody's going to essentially probably be paid the same. Likewise, as usual, when all of the components of the code are not performed, then you go back to using the traditional Tier 1 or Tier 2 codes for specific genes, or you have to use the unlisted molecular pathology code 81479. So we'll start in here, and I'm not going to spend a lot of time reading every one of these codes, except to note how they're structured. And the first one here for aortic dysfunction is pretty typical. It says, it describes the clinical use of the test, and then it says it must include at least 9 genes, and it lists the specific 9 genes. Now, if you do duplication and deletion analysis, that has a separate code, and it also has its own list of included genes that must be in that code in the analysis and able to use the code. The new code for chromosomal aneuploidy, again, this one does have a specific specimen description. In other words, it's only for circulating cell-free fetal DNA in maternal blood. Again, in this case, you must include 3 chromosomes, 13, 18, and 21, in the analysis. The hearing loss here, again, is very, very similar to the first one. You have a list of, in this case, you have to have at least 60 genes, and you have to have this set that's listed here as part of that 60 genes. And again, there is a separate duplication deletion analysis panel code to describe duplication and deletion. Hereditary colon cancer, pretty much the same, as you can see, same format. Likewise, the nuclear encoded mitochondrial genes. So again, these are essentially information slides for you, so that you've got a record of it here. These descriptions obviously come right out of the CPT book. Likewise, there are 2 codes for whole mitochondrial genomes. And again, the only requirement here is that it must include sequence analysis of the entire genome. And again, falling back to that rule, if you do not do exactly what is specified here, you cannot use the code, obviously. Now, there are 2 codes that will no doubt cause a lot of problem for pricing, at least, and what they'll be paid for. And these are essentially codes looking to the future as much as they are at present, and that's for exome and genomes. There are 3 codes in each of these sets, and the interesting thing here is, in addition to the exome or genome, there is also a code for comparator exomes or genomes that might be run. And also, the most unique feature is for reevaluation of previously obtained sequence data. So the assumption is that eventually patients at some point in their life will have possibly their whole genome determined, but it will only be paid for by insurers and payers if that patient has a need for it, meaning they have a disease or something wrong with them that is a covered situation. So they're going to have cancer or something that brings them to that situation of being able to be covered by their payer. And when that occurs, they will probably only be interested in a targeted set of genes for that particular disease. But they may indeed have their whole genome analyzed and stored someplace. And then later on, if either the disease changes or later in life they're cured of one cancer and they get another, et cetera, there may be a need for reevaluation. So that third code in these two sets is an interesting code that it's not a test, actually. It's a data analysis. And of course, the whole issue of who's going to pay for the long-term storage of genetic information that can, end up in terabytes of data is still totally up in the air as to who or what or if somebody's going to pay for that. So these will probably be the most difficult codes for payers to decide what they're going to pay. And I wouldn't be surprised that some of them simply don't get priced immediately because most payers, of course, haven't been asked to pay for a whole genome yet. The codes that will probably be most used in this series, in which virtually all of the questions that we get are about the three codes on this slide. And these are essentially the neoplasm codes. Pretty straightforward. The first one is for solid organ neoplasms and for 5 to 50 genes. So any panel of neoplasm genes that you run that exceeds 5, you're going to be thrown into this particular code. Now here you notice they do not specify required genes. The EG in the description is for example. So, these are simply examples of the typical genes. You can run any clinically valid set of genes or other measurements, that you want, and you still end up with this code. The next code is virtually the same. It's, of course, for hematological neoplasms as opposed to solid organ. And then the last code is if you exceed 50 genes for either solid or hematological, then you're going to end up with this code. And these are the type codes that would, they describe the foundation medicine assays, for example, and so on in the future. And so you'll see these will be the most important to be priced in the next few months because I think this is where most of the action, so to speak, will be in terms of actual tests being performed for patients. There's also codes here for X-linked mental disability. And again, this goes back to the must include and has at least 60 genes, et cetera. Very specific requirements for that. Now we get, though, to how does Medicare at least plan on paying for these particular new codes. And unfortunately, at least by my opinion, they're using, again, the gap-filling process. And what this really means is that starting out already this year, each Medicare contractor has to come up with their own payment for these new codes. So when you send in one of the codes, you will get a payment that should be based on charges, resources, and payment amounts by other payers, et cetera, this list of criteria. Now, in actuality, what tends to happen, a lot of these will probably end up being compared to the MolDX program from Palmetto, where similar procedures have already been given Z codes and priced out. Some, obviously, a lot of payers will already be paying some of these neoplasm codes. So it'll be very interesting to see what the effective payment rate ends up from the various contractors, because this is essentially how the final payment will be set. So what will happen during this year, by April 30th, CMS will post the interim contractor specific amounts. In other words, what each of the Medicare contractors is paying. Now, if this follows the same pattern as with new codes for molecular pathology in the past, some of these codes probably won't have published amounts. For example, the whole genome code nobody is going to pay for it probably yet unless they got a claim. You may not see a posting on that. So there will possibly be some holes in the fees schedule, for these new codes when they do get published. After that posting, there's a 60-day comment period where the public's free to comment on the appropriateness of some of these payments. After the CMS looks at the comments, usually in early September, they will then publish a final payment schedule, and it is based on the median of the different contractor amounts for each code, not the average, but the median. In other words, the value that there's an equal number of higher values and lower values submitted by the various contractors. And again, the payments are by state, even though there are only, I believe, 13 MACs right now functioning. But each of the states in a single MAC, they may all be the same, but each state is essentially counted as a separate payment. Even after that is set, there will be another period of 30 days where people can ask for reconsiderations, but the final numbers will become effective next January, and they will be uniform for everybody. There will be no variation by state or locality once these amounts are set. Now, we mentioned earlier that we're going to talk about the MAAA codes. The issue here is that there's two new ones, for example, which are good examples of what an MAAA code is, as you see, like tissue of origin. It's a microarray gene expression of over 2,000 genes, and it uses an algorithm as a tissue similarity score. CMS has thus far refused to place these on the fee schedule, so there's no official price on these type of codes, either the existing ones or the new ones. However, they've come up with at least a payment policy, and that is simply that they've told the contractors to gap fill such codes if they determine them payable. So the contractor still has to decide if it's a covered service, and then they can consider each one individually as to what it should be paid based on the charges, obviously, and all these other factors. In general, this is what's happening when an MAAA is involved. And remember, if at any time you apply an algorithm that results in a single result that combines information from a number of genes and other tests or physiological parameters, that throws it into an MAAA position, and you cannot use the regular molecular pathology codes and the NGS codes. There's another aspect of everything that's going on, for the most part right now, can be considered a threat to pricing of lab tests. It doesn't matter whether it's in routine lab or anywhere else. And one of the things that Medicare has changed over the last 2 years is for emergency room and outpatient clinic payments. Last year, they started bundling all of these payments for routine lab tests into the fee that the ED or the clinic received to treat the patient. So it was like rolling all of the test payments into the office visit, so to speak, no separate payment. For 2015, they have expanded that to include the technical component of pathology services. Almost all pathology services are included in that, and also are rolled into that ED or clinic visit. Now, what about molecular tests, though? Interestingly enough, there's a few places where the tests are not bundled, and for our purposes, a very important one is that all of the molecular procedure pathology tests, including the new codes, would be included in this. So molecular pathology tests performed for an outpatient or in an emergency room are paid separately and will continue to be in the future. As you can see, the only other things that are paid separately is the professional component, the physician component, of pathology services. And if a patient presents with only a script essentially to have a test performed, that is not bundled in either. They're not considered a clinic visit in that case. So let's now talk a little bit about coverage policy, because there's always the two aspects. You can have a code that applies to your procedure, and it may be on the fee schedule and have a price, but if it isn't covered, you still don't get any money for it, obviously. So genetic testing, and especially in the cancer area, and as we've discussed, is relatively new, of course, and it's a very fast developing and fast growing area. So what typically happens, of course, is that there is no national coverage policies for DNA-based testing at this point. But a number of the Medicare contractors and commercial payers are developing and have developed policy for at least mainly cancer diagnostics. And that's what we'll talk about mainly here, to give you an idea of the overall direction of where these policies are going. They're going to be unique to individual states in the case of Medicare. As you say, you have national coverage determinations, but we don't have any that apply at this point to molecular. The only general restriction is that Medicare, by law, does not pay for screening tests, as they call them, meaning tests for patients with no symptoms of a disease or a malformed body part. So you will not be able to be paid for any test where you don't have a clear indication of disease, and that the test could possibly help in the diagnosis or the treatment of that disease. So that eliminates, just general information testing. Now, the local LCDs are very specific when they're written, and they indicate exactly when it's to be covered, how often. They usually list a specific short list of covered diagnosis codes and tell you specifically, what documentation has to be in the patient record in order to be paid for that test. So in that sense, they are very detailed, and unfortunately, they sometimes only treat the most common issues, and then the rest are all lumped into a non-coverage situation. So local coverage determinations for Medicare are developed by the contractor. And again, so they'll differ from state to state. They cannot contradict national policy, but since we don't have any, that's not an issue. And they, of course, give you specific information as to what will be covered when you submit that test. Now, an important aspect as these new policies are published is the fact that the public, any stakeholder, has the right to ask for a revision or a change to those LCD. Such changes can be initiated by the contractors themselves as new information becomes available. And oftentimes, for example, the list of covered diagnosis changes actually on a quarterly basis for many of these procedures. So you have to be on top of that as well. And the key thing again here, a lot of policies can either be added or retired on a quarterly basis as well. But the important thing is to remember, when you see a bad policy, you do have the ability to ask for a reconsideration of that policy based on published articles and evidence, and oftentimes you can fix them, so to speak. So just as a general description of what coverage depends on right now for molecular, I'm using a Wisconsin Physician Service LCD here as an example. In general, the person has to have a personal history of illness, injury, signs, or symptoms. In other words, what they call a clinically affected person. Interestingly enough, a person with a history of cancer, even if it's cured or in remission or whatever, is still considered clinically affected. So once you have a history of any sort of cancer, that's no longer considered a screening test if it's appropriate for the physician to order a genomic test or a DNA-based test. On the other hand, predictive or pre-symptomatic genetic tests are not covered. So just because you have a family history doesn't mean it, but if you have a personal history, it will generally be covered. Another very general but basic rule is that the test has to be used to manage the patient. If the information is purely informational and there's nothing that can be done to alter or predict the prognosis or otherwise manage the patient, it's not going to be covered. And some of the reasons for non-coverage, for example, they're not going to cover family planning, risk assessment for other family measures, or, as I said, anything that doesn't directly affect the patient or the beneficiary. Typically, these policies are written paragraph by paragraph, you might say, for specific cancers. So in this particular policy, these are the different cancers that are addressed in the policy. And as an example, for the hereditary breast and ovarian, it says they will cover BRCA1 and 2, who has had breast cancer, or ovarian and fallopian tube peritoneal cancers. They give you specific CPT codes. Those are the BRCA gene code, essentially, that are covered. Now, this policy does not include any of the new codes because it was written prior to that and hasn't been updated yet. So at this stage, it has only the individual genes that they considered covered. And then on the diagnosis codes, there are 18 very specific ICD-9 codes that are essentially for malignant neoplasms of these particular anatomic sites. An interesting thing, and we're going to talk about PAMA next on the agenda here, but one of the inclusions in that legislation is that, effective now, MACs can only issue coverage policy in accordance with the official regulations on creating and issuing LCDs, and which means that they have to toe the line on the regulations which require comment periods, reviews by expert panels if necessary, and things that basically result in a transparent creation process for local coverage with a lot of participation. They can't arbitrarily just put out a guidance document that says we're going to do this or this, and that's the way it is. The other interesting thing that concerns the LCD process and MACs is that there's a provision in PAMA that says CMS can designate 1 or up to 4 MACs to essentially cover all and process all laboratory claims. And this is an interesting thing in that it seems to indicate that CMS would like to move to a national both contractor basis and possibly payment basis for laboratory tests. It remains to be seen if anything will be done about that permission, so to speak, that was granted in there. It just says that they may do it if they want to. So that's sort of a little intro now as far as PAMA is concerned. And this is market-based reimbursement for lab tests. This legislation was passed late last year as part of the bill that extended the fix of the doctor's, physician payment fee schedule. But it is probably the most complex and radical set of legislation affecting laboratories since the creation of CLIA back in 1988. So we're going to give you the essence of it, and as usual, the devil will be in the details of the actual regs. All we have now is the law and what it requires. When it happens and how it happens is up to CMS, and so there's a lot of loose ends that'll devolve. There will be a lot of unintended consequences, a lot of controversy as this rolls out in the next few years. So what are the key provisions in this act? First of all, it simply delayed the physician fee schedule cut through actually the end of March of 2015. So they're still going to have to deal with it. And it delayed the requirement to use ICD-10 codes until October of 2015. But most important, and 95% of the statute is creating a market-based payment system for all clinical tests that currently exist, plus what they define as advanced diagnostic tests, which, as you'll see, very, very much will fall into the DNA-based molecular pathology area. So, starting January of 2017, payment will be based on rates paid by commercial insurance. Medicare rates will. And this includes Medicare Advantage plans and Medicaid managed care organizations. So during 2016, next year, laboratories will have to report the volume and amount received from all third-party payers for all tests performed over a certain period of time, maybe the whole year, maybe 6 months. As you can tell, that's a pretty dramatic requirement in terms of data that's going to be required. And nobody knows yet exactly who has to submit, how much, how they'll do it, or any of those things. So this is one of those things that are typical in legislation. It's 2 sentences there. It will generate thousands of pages of regulations, comments, and implementing criteria. So then what they're going to do is, effective the 1st of 2017, the payment for each test on the clinical lab fee schedule will be based on the weighted median of all payment amounts for that test. In other words, how many instances of a given payment for, from all commercial payers, you're going to look for the midpoint of that. How many are above and how many are below, and that will become then the Medicare payment. So, in a sense, this is kind of like they pay for drugs, where they pay the average wholesale price. That's, I think, the intent of where they're trying to go here. Now, underlying all this is that CMS believes that they're overpaying for a lot of lab tests in terms of what their actual cost to perform is, and that may be the case. But they're also underpaying for a lot of things, or not paying at all, so that it all kind of averages out now and gives you a positive economics situation. It'll be very interesting to see how this rolls out, obviously. Now, there are some stopgap, or whatever, well, insurance points we'll call insurance in this legislation. Number one, the payment reductions. If it turns out that a test, the average commercial payment is, let's say, 50% below what Medicare is currently paying, they can only deduct 10% a year. They can only reduce it 10% a year for the first 3 years after 2017, and then 15% for the next 3 years. After that, they can go as low as they want. But if you look at it, that takes it down to about 45% right there. Again, every 3 years, they will then resurvey all of the labs and adjust the payments according to what commercial payers are paying. Who must report data? This is going to be the first big argument that they have to solve out there. they have the permission to essentially not ask for data from low volume or low expenditure laboratories. They don't have to ask for data from POLs, for example, and physicians who run a few tests. So they have to set this criteria is what it amounts to. But it says that any laboratory that primarily performs tests on the clinical lab fee schedule must report the data. And there's still a big argument, and it's unclear in the legislation whether even hospitals are included in this or not. Because if you say that the whole hospital's revenue is the basis, then, well, they don't primarily perform tests from the clinical lab fee schedule. On the other hand, if the hospital laboratory is the entity, then they do. So there's all these interpretations and regs that will have to be developed. There's severe penalties if you don't report or if you falsify information. First of all, a laboratory officer has to certify the accuracy, meaning that there will be personal liability if you lie about it, obviously. And then failure to report is subject to a penalty up to $10,000 per test per day. And as you can see, that really could get expensive if they enforce that aspect. So once they tell you what you have to report, everybody's pretty much going to have to do it. So going back to how does this all happen and what's the timeline? By 2015, by the end of June, the legislation says that CMS has to start issuing the first regulations on who is to be surveyed and how they will survey the pricing. So we only have 3-4 months to wait. Right now, there's been no inkling that anything's going on. During 2016, the volume and payment information will be collected, and then in 2017 through 19, you'll have the first 3 year of market-based payments. Then they'll do again another survey in 2019, and likewise then adjust and go forward each 3-year period that way. Well, how will tests be reimbursed prior to 2017? Essentially, the answer is the same as they are now. In other words, the same CPI, productivity, and other adjustments will continue to apply. We still have the 2% sequestration. So you can expect reimbursement to probably be reduced 1 to 3%. This year it was only less than 1%. So it'll be modest at the worst, but it'll proceed until 2017 exactly as it's occurring now. So how will new tests be priced under this new system? Several aspects in here. They'll continue to set the initial price by crosswalking or gap filling, just as they do now. And the annual laboratory meeting will be used as a forum to gather stakeholder comments. There will be a new expert panel created, and actually the regulation to create this panel and the asking for who can be on it has been published. So at least they have done that. Also, the law says that when they do price new tests, that CMS must explain the basis, which they don't do too well right now. And of course, once they're there, they will go to probably a no geographic variation. I think you're going to eventually see a national lab fee schedule under this. Now, another important definition in PAMA is advanced diagnostic tests. And as you see, this is a test offered and furnished by a single laboratory. So it's a lab-developed test, typically. It's proprietary, not sold by any other lab, and it meets one of these 3 criteria. The most obvious one is it's multiple biomarkers of DNA, RNA, or proteins. So obviously this encompasses a lot of lab-developed DNA-based tests in the future. It can also just be a test cleared or approved by the FDA or other criteria, which who knows what CMS may come up with as a final definition of an advanced diagnostic test. The reason that these are important, though, as a separate type of test is how they will be paid for. As soon as you go to market with that test, the initial period of 3 quarters, they will pay your list charge for the test. After the first 3 quarters, you have to report the actual payments you received from all private payers, and then they will set the rate at the median of those payments. If you have an excessive list price and you get nothing near that from the commercial payers, so if it exceeds it by more than 30%, CMS can recoup the difference. They can ask for it back. So what does this mean? It says that no longer will you be worried that much about what Medicare is going to pay, because that'll all be based on what you can get the commercial payers to pay. On the good side, it says that if you've got a test that has downstream savings, a real economic value to the payer, you may be able to actually get a value-based charge on that test and get paid for the savings, so to speak, that can result from using it. Which right now, the current system of gap filling and crosswalking is really a cost-based or a comparable-based system, which is pretty arbitrary. So there may be some good aspects to this, especially for genetic laboratories, with these new advanced diagnostic lab-developed tests. Once it's set, then it'll be priced, of course, every 3 years, the same as all the other tests. But this could be a very important aspect of payment in the future. There's another, pretty much the last item we'll talk about under PAMA. It says that CMS has to create new codes, again, by the 1st of 2016 for all diagnostic tests, advanced diagnostic tests. Also, though, for each existing laboratory test cleared or approved by the FDA, and anything that's currently paid under the clinical lab fee schedule. This could be easily 2,000 to 3,000 new codes of some sort that have to be created. The purpose of this, apparently, or the intent, is so that every test has a unique identifier when they start pricing it, getting pricing information, so that you don't roll a whole bunch of tests, into a single code or something and have a single payment, which is kind of contradictory to what we just saw in the new NGS codes. Those are very broad codes. They can encompass tremendously different technology and methods of fulfilling that code. So those codes may still exist, but if laboratories develop unique lab-developed tests, those can all be coded separately under the advanced diagnostic test. There's also the question of many tests on the clinical lab fee schedule are currently coded either with unlisted codes or with method codes. Those presumably would have to be broken out into specific analytes and even specific specimen requirements. So it'll be very interesting. Another tremendous job for CMS to somehow get their arms around. We already mentioned the issue of coverage policies, so this is essentially a reiteration of that they have to stick to the regulations and the rules for coverage. That is pretty much it. So this last slide is just my contact information. If any of you have questions or so on and want to get in touch, feel free to do so. So I will turn it back to Ben now for questions.
Wonderful. Thank you, Dr. Root. We have some questions rolling in, and I want to encourage others who may have questions that have come up to enter them into the question bin within the GoToWebinar controls. So, Dr. Root, let's start kind of back at the beginning. You talked about these genomic codes as there were a couple key terms in there. One of them was the clinical relevance. So we have a question of how can a whole genome or a whole exome with 22,000 genes be considered clinically relevant? Or actually, the specific words in there, I think, were clinically relevant genes. So exome, genome include genes that people know very little about.
Yeah, that's an excellent question, and that's why I say that those codes in particular are going to be very problematic in everybody's mind until some of these issues get thrashed out. You could go two ways here, and presumably it'll eventually come down to economics. In other words, is it more economical to simply do a whole genome and have it all done at once, or is it more economical to do very specific targeted tests? And even if you did the whole genome, if it included the specific genes to enable you to treat the patient for whatever is currently their problem, that could be considered a covered service. On the other hand, if it was excessively expensive to do that, Medicare would probably, and most payers would object to that. So as you say, this is a very open issue, and it's going to have to evolve over the next few years as to, and it is going to boil down to, technology and economics for the most part as to what makes sense, I think. Right now, it would not make sense probably to do a whole genome if you just needed a cancer diagnostic set of genes, of a couple of hundred genes.
A related question that I had was about what actually is the definition of an exome or a genome. So some of those indication-specific codes listed specific genes that needed to be covered and a minimum 100 genes for your nuclear mitochondrial testing. So what would the definition of an exome or genome be? Is that something that's going to be worked out between all the related parties here?
Yeah, that's exactly it, in that things like the exact definition, those will either be one place, obviously, it would occur would be in the coverage policy, and that's where it would be defined as to the details.
Great. So another question that came up was about the RNA sequencing versus DNA sequencing. I think you did cover this, but these tests in theory are completely open to both. If somebody's doing a transcriptome sequence, that's effectively equivalent to an exome sequence at the genomic DNA?
Yeah, in other words, the intent of the codes is to include both RNA and DNA. You can
Great. And
be based on either.
So then the related question there, what about proteomics? What about other metabolomics and other fields like that, other similar, very large-scale bioassays? Are codes for those coming? Do they exist?
Yeah, there's nothing that exists right now, as you say, in proteomics. One would logically expect a somewhat similar set of codes may eventually evolve for there as the technology evolves.
Okay, great. So a very specific question then about the genome and exome codes. You showed how there were 3 codes for each, and they were really fascinating actually. So you've got the patient's sequence, family members sequence essentially, and then the reinterpretation. So there's a question about that second one, the idea of the family member test. So the question is, are those codes used? Those are billed to the patient, to the proband, not under the family members to the family member?
Yeah, well, as you noted, at least in the initial coverage policy we have, it excludes coverage for any family members, or as implied by family history as well, is not a covered reason to do the code. So I think the second code you're going to find is generally not going to be a covered payable code, because most payers, the only place you get into this is in like organ transplant, where there it does go essentially to the recipient's account, so to speak, that the insurance for that patient will cover the expense of the donor. So, but that's about the only kind of similar situation we have where other individuals are involved in the diagnosis. But as you say, I think it's unlikely that you'll see family member testing covered, especially under the patient themselves. The attitude of the payer will be, we'll wait and see if you develop the disease, and then we can test you.
Right.
That's basically their criteria.
Okay. How about chromosomal microarray tests? Is there any effect of these new codes in relation to those?
Not really, because they will include microarrays. In other words, so right now they're method independent. So you can do about anything that fits in there, and if it slots into those codes there, you can use them. And if it doesn't right now, it just goes to the unlisted.
Except that these new codes seem to be about the word sequencing is specifically in the definition. So if it's simply a probe about presence absence, looking for chunks of a chromosome that are missing or duplicated, that would be a different kind of assay and different coding altogether, wouldn't it?
It could be. I think right now the interpretation would be anything of that sort also falls in here. So in other words, the title of the section of sequencing, when you read the actual instructions, they are quite broad and essentially include all of these other aspects as well. And
okay,
again,
that's
it's not real clear. And those are some of the things that, well, we're already seeing that in that the first modifications of these codes are now being proposed to the AMA, and if you look at their agenda for the meeting coming up in a couple of weeks, there's about 10 or 12 new or modified sequencing codes, as they would be called. But some of them I don't think have anything to do with sequencing. They're either expansions or definitions or subcategories, of the existing codes.
Okay. Back to the question about the family members. Somebody's asking about parental testing to help elucidate an abnormal test on a baby or fetus. Same answer?
Yeah, I think something like that. Again, if it affects the fetus directly, and how what you might do to manage that pregnancy, then it's a good chance it would be paid.
Got it. So here's a concern. A concern that commercial payers will simply underpay or not pay at all in 2016 in order to keep CMS pricing down in 2017 and beyond. How is that working of the system going to be addressed?
Well, I'm not sure that the only answer I really have is based on our experience with what has happened over the last 3 or 4 years as the gene-specific codes, were rolled out in much the same manner. But we have the case actually right now where the commercial payers are probably paying better overall than Medicare is. And I think that's one aspect of looking at, they might try to do that, but it's kind of a conspiracy theory thing that I'm not sure that's their typical behavior. As you say, I tend to be more on the positive side that when the commercial payers are more susceptible to a value-based pricing argument, I think, than Medicare is. So that you can look at that at the positive side. On the other hand, there could be some of this, well, let's hold the prices down because we know Medicare will pay the same, et cetera. It's, as you say, that's one of those not an unintended, but totally unpredictable responses to this sort of change, where it turns everything on its head.
Right. So towards the end, you mentioned this new requirement that by January 1 of next year, that there need to be new codes for existing laboratory tests cleared or approved by the FDA, which is a fair number. But what about all of the existing laboratory developed tests that are not approved by the FDA? As you know, that's a big topic of conversation there. So what about all these tests that are out there already? So tests by Myriad, Ambry, and other commercial providers in particular who have these large panels.
Well, I think it would include those, and at least I think that's the intention, because the language is for every unique test. And so either those tests will end up as advanced diagnostic tests, or the other thing that I think predict is that when CMS defines advanced diagnostic tests, it includes most of that type of lab developed test, because you almost have to, the spirit of that clause in there is that you want to be able to identify everything, and certainly you want to be able to identify lab developed tests as well as other types.
Well, sounds good. There's an awful lot of change. Thank you for sharing with us today. Much of your expertise. I'm sure there's much more we could probe with time. And thank you everybody for coming today. It's been a pleasure having you. The webinar, as a reminder, was recorded and will be available afterwards. And I think we got through all the questions, but if you have follow-up questions, please feel to shoot them out to us. Thank you all and have a good day.